a diagnostic approach to lymphadenopathy and brain tumor in children. Approximately 50% of children older than 5 years seen for well or sick visits had lymphadenopathy. The likelihood of malignancy within the node will determine the urgency with which biopsy or other invasive procedures are undertaken. It must be emphasized that not all palpable nodes are pathologically enlarged and that most pathologically enlarged nodes are benign. Factors of importance are the age of the child and size and location of the lymph node. For children less than 6 years old, the most common head and neck masses presenting with lymphadenopathy are the following, with neuroblastoma as the first tumor to be considered, rhabdomyosarcoma, non-Hodgkin lymphoma, and leukemia. For children aged 7 to 13 years old, non-Hodgkin lymphoma is the most common, followed by your Hodgkin lymphoma, thyroid carcinoma, and rhabdomyosarcoma. For children aged 13 years and older, Hodgkin lymphoma is the most common. Lymph nodes are dynamic structures that can widely fluctuate in size, especially in children. The nodes of the neck, axilla, and groin are often palpable in normal children. Cervical and axillary nodes greater than 1 centimeter in diameter are considered enlarged, as are inguinal nodes greater than 1.5 centimeter in diameter and epitrophia greater than 0.5 centimeter in diameter. Palpable supraclavicular nodes should always be considered abnormal, with left-sided nodes, also known as your virtuous nodes, suggesting metastasis from an intra-abdominal malignancy, such as neuroblastoma. Right-sided nodes suggest also presence of intrathoracic disease. When evaluating a child with adenopathy, it's important to distinguish between generalized and localized lymph node enlargement. Generalized adenopathy usually involves more than two non-contiguous areas, and usually this could be caused by many disease processes such as your infection, autoimmune illnesses, and also malignancy. For localized adenopathy, this would involve enlargement of lymph nodes within contiguous anatomic region, and usually this could be due to infection or malignancy. Nodes that are more likely to be malignant or will give us a red flag are those that are large, usually with a size of more than 2 centimeters, with a characteristic of non-tender, firm and rubbery, or rapidly enlarging that usually persists for more than 6 weeks and does not respond to antibiotic therapy, with an epitrochlear or supraclavicular location associated with coexisting signs of fever, night sweats, weight loss, malaise, pallor, and hepatosplenomegaly. This would further warrant an evaluation, particularly with baseline complete blood count and chest X-ray, and already could be an indication for a biopsy. Here is an algorithm that would help us or aid us in diagnosing presence of enlarged lymph nodes. We could further categorize it as a non-suppurative or a suppurative cause. For non-suppurative cause, we would further divide it into a local infection or non-local infection. For local infection, culture and serology would already be of help. For non-local infection, significant anemia with hemoglobin levels of less than 10 grams per deciliter, presence of cytopenias, leukoerythroblastic changes or blast cells on smear, or a mass on chest radiograph all point to the need for a bone marrow aspiration as the next step in evaluating adenopathy. In patients with only anemia or abnormal chest radiograph, examination of the marrow may not be diagnostic. Immediate biopsy of the node is indicated when the marrow does not provide a diagnosis. Patients with normal CBC and chest radiographic findings, but who have negative skin tests for mycobacteria and serologic findings, may be given a 1 to 2 week trial of antibiotic therapy. If the nodes are rapidly enlarging or if their size does not decrease considerably during antibiotic therapy, then a biopsy is necessary. Indications for lymph node biopsy are the following: presence of chronic, persistent, progressive adenopathy, wherein infectious etiology has not been uncovered, dominant node persistent for more than 6 weeks, any nodes more than 2.5 centimeter in diameter in the absence of signs of infection, lymph nodes located in the supraclavicular area, and lymph nodes associated with systemic symptoms. So all of these indications are already indications for a lymph node biopsy. A fine needle aspiration cytology has a high specificity between 92 to 100%. However, sensitivity varies between 67 to 100%. A fine needle aspiration cytology cannot be relied upon to exclude malignancy in children. If a lymph node biopsy is needed, an open excision procedure is preferred. It is a dictum that we should avoid glucocorticosteroids before a diagnosis is established for us not to mask any associated symptoms that would hinder our diagnosis. Okay. So the most common malignancy associated with an enlarged lymphadenopathy is the presence of lymphoma or cancer of the lymphatic system. Usually, this develops from lymphocytes located in your lymph nodes, spleen, thymus, and bone marrow. We have two types of lymphoma, your Hodgkin and non-Hodgkin lymphoma, wherein non-Hodgkin lymphoma is the most common. To differentiate the two, Hodgkin lymphoma is more localized, involving single group of nodes. For non-Hodgkin lymphoma, this usually involves multiple lymph nodes. Hodgkin lymphoma would involve contiguous spread as opposed to your non-Hodgkin lymphoma, which is a non-contiguous spread. Extranodal involvement is uncommon for Hodgkin lymphoma, while it is commonly involved in Hodgkin lymphoma. The pathognomonic cell for your Hodgkin lymphoma, usually noted in biopsy, is the presence of a Reed-Sternberg cell. As for non-Hodgkin lymphoma, B cell and T cell involvement is seen or usually the pathognomonic cells wherein B cell is more common. In history taking, the most common presenting signs and symptoms for lymphoma are as follows: an unexplained fever, presence of weight loss, drenching night sweat, malaise, and anorexia. The first three, the unexplained fever, weight loss, and drenching night sweat, comprises your these symptoms. When for the physical examination, we should take note the following. For the head and neck, presence of either supraclavicular or cervical adenopathy, or sometimes with jaw swelling. For the abdomen, we can palpate the presence of a splenomegaly. Some patients would have presence of abdominal distension and jaundice. And for mediastinal masses, usually patients would present with cough, chest pain, and stridor. So these are the following signs and symptoms that would already warrant us for further evaluation and would give us the red flags in patients presenting with lymphadenopathy. Evaluation and diagnostic workups include your imaging, CT scan, particularly CT scan of the neck, chest, abdomen, and pelvis. PET scan and bone scan could also be of help. But of course, the definitive diagnosis would still be an incisional biopsy. So in summary, the most important part of your diagnosis would still be a history and physical examination being the key tool in diagnosing and subsequently management for patients with lymphadenopathy. Lymph nodes more than 2 centimeters in diameter should always be considered malignant unless proven otherwise. Lymph nodes presenting in the supraclavicular area or associated with systemic symptoms warrants further investigation and workup. And of course, given all these symptoms, an immediate referral to specialists is already warranted for us to manage the patient properly. For intracranial masses, brain tumors are the second most common group of cancers in childhood. Approximately 20% of all childhood malignancies are the brain tumors. The most common CNS tumors are as follows: your astrocytoma, medulloblastoma, brainstem glioma, and ependymoma. Signs and symptoms associated with childhood brain tumor are usually nonspecific and can vary from localizing symptoms related to direct effects of tumor or surrounding brainstem or spinal cord. Some also would be are related to obstruction of cerebrospinal fluid flow and resultant hydrocephalus. So the most common symptoms in this graph would be a headache, presence of vomiting, unsteadiness, and visual difficulty. Some would also present with behavioral changes and seizures. These symptoms range from more general symptoms, such as enlarging frontal occipital circumference in an infant, chronic or recurrent headache as mentioned, cranial nerve palsy, presence of seizure, ataxia, and visual defect. Headache is a common symptom among children and adolescents. Recurrent morning headache that awaken the child, intense and incapacitating headache, and changes in the quality, frequency, and pattern of the headache should already be a red flag for children with such symptoms. It should also be noted that in infants, symptoms of an intracranial mass may be quite different and indicate irritability, increasing frontal occipital circumference or bulging fontanelles, seizures, failure to thrive, and developmental delays or regression. So this table would already show us the different signs and symptoms associated with central nervous system tumors in children. Also, this could be already considered as the red flags in page and when we are considering children with brain tumors. Here are presenting signs and symptoms based on location of tumor masses. For posterior fossa, patients could have presence of nausea and vomiting, headache, abnormal gait or coordination, pupil edema, and abnormal eye movements. For brainstem lesion, red flags that could be seen in patients could be abnormal gait and coordination, cranial nerve palsies, nystagmus, focal motor weakness, and signs of increased intracranial pressure. For patients presenting with spinal cord, patients usually present with back pain and or weakness, loss of bowel or bladder control, and gait abnormalities. For supratentorial masses, usually patients will complain of headache, seizure, hemiparesis, hyperreflexia, and orthosis, sensory loss, speech disturbance, memory deficits, and personality change. So when do we need to worry, or what are the important red flags, as we mentioned already a while ago? So again, in summary, if the headache is new at onset, usually persistent for more than 4 weeks, usually noted in the morning, sometimes awakening the child, if it is associated with vomiting and the headache is usually intense and incapacitating, sometimes with associated neurologic deficits, and presence of headache in child less than 4 years old. This would already warrant further evaluation, especially your neuroimaging. So this table shows the diagnostic strategies for children with headache suspected of having a brain tumor. Headache more than 6 months and not associated with any neurologic symptoms are considered as low risk group with a probability of brain tumor of less than 0.01%. For this, a diagnostic strategy would include no imaging, and usually we just monitor the patient and sometimes give, or most often, give medical treatment. For migraine headache and no neurologic symptoms, these are the intermediate risk group. The probability of brain tumor is 0.4%. We could request the following: CT scan, cranial CT scan, MRI, followed by biopsy or surgery. For headache less than 6 months with associated neurologic symptoms or signs, these are the high risk group with a risk group with probability of brain tumor 4%. And of course, your neuroimaging is of help, particularly your MRI, followed by biopsy or surgery. In summary, the best method of screening brain tumor is a careful history and neurologic examination. Patients with headache and neurologic symptoms are those children who presents with more localizing symptoms such as focal weakness, cranial nerve palsy, ataxia, visual loss, or seizure should undergo neuroimaging or evaluate for intracranial pathology, since this could be early signs and symptoms of an impending brain tumor. And the classic triad for suspicious brain tumor are the following: headache, which awaken the child from sleep or are present on arising, associated with vomiting and papal edema.